So hi everyone, thank you so much for joining. ISPS-US looks to be the cross center, the bridge between academics, providers, the lived experience community, and family members. Um, Sorry if I'm forgetting anybody else, but those are the four groups that come most to mind. And how each of these can learn from each other and kind of develop new ways to help those going through the experience commonly labeled as psychosis. So we're very lucky to have Al and Brittany today. I'll mostly let them introduce themselves, but just give you a bit of background from my perspective. Um, the academic side of thing has, for a very long time, focused on pharmaceuticals and kind of the labels of schizophrenia. And so I'm very excited that Al and Brittany are kind of trying to redefine the research, redefine what academic approaches look like for psychosis, and focus on non-pharmaceutical coping techniques and strategies. They also have an amazing story, both each their own and together. And kind of with that, I'll hand it over to them. For the first 45 minutes, they'll just tell their story, kind of tell you what they're working on, their insights. After that, I'll ask them a few questions that I had prepared. And throughout the webinar, just chat your questions, and we'll get to them in the last half hour. So any questions you have, we'll take notes. Then Al and Brittany will tackle that in the last half hour. Cool. Al and Brittany, you're up.
Awesome. Britt, I'm gonna defer to you.
Defer to me. All right.
Defer to you.
I wish you could feel my heart racing right now. Well, I do want to thank Dimitri first for having us on here. I think this a really awesome platform to be able to share our story, share the work that we're doing, but also hear from everybody about what their interests are and their concerns, and build a lot of energy around what we're trying to achieve here. So thanks for giving us the opportunity to do that. And thank you to everybody for joining. It's great to have people to actually talk to about this. So, well, Al put me on the spot, which means I guess I'll start. My name is Brittany Quagan. I'm a licensed therapist, and I'm also the co-director of the COPE project along with Al. And while I am here to talk a little bit about the research that we're doing, I'm also a person with lived experience. So because of that, this project is one that is very near and dear to my heart. And to give you a little bit of background story about my experiences, I've basically dealt with mental health experiences since I was basically born. I was born a hypochondriac. My parents like to joke, like just always worried about things. So my mental health journey really started with anxiety, and it really sort of escalated into, it was teetering a little bit on paranoia there for a while, coupled with depression and suicidality. And when I was about 16, it's so hard for me to actually gauge the age. It had to have been between 15 and 16 that my suicidal thoughts became a little more prominent. And it's when I really started to struggle a little more with self-harm and things like that. And it was around that time that I started to hear voices as well. It's something that I think is really important to share about my voices, is my voices were actually something that saved my life rather than caused me harm. Because when I was in those really dark moments, I guess you could say, I would start to hear this voice similar to a male voice, but also this British woman telling me that if I were going to kill myself, I'd be basically missing out on all these great things that I had to do, like helping people and writing books and all this fun stuff that I feel like as a clinician, and how we understand depression and suicidal thoughts, you're not often sitting there empowering yourself while you're also thinking about killing yourself. So for me, it was like this almost divine thing coming forward to help me out of that. And while I did and still do experience them very external from myself, or I see them very different from myself, it's something that helped me tremendously. And for me, my struggles really weren't so much with hearing voices, but it was other perceptual experiences that I had that I really struggled with, specifically like tactile hallucinations, I guess we would call in the clinical world, really freaked me out. I would feel things all the time. I would feel things watching me. I would feel things in my body that would always make me feel like I was sick and dying. And I was pretty convinced all the time that I was dying. My doctor used to joke that they were going to get, like, it's funny, we talk about Batman, they were going to get like a Batman line for me because I called every day. And they were like, oh, we just have to have a hotline just for you because you call every day thinking you're dying. We got to get all these tests for you all the time. Yeah, so my struggles really were around more the things that I felt. And sometimes the things that I would see would overwhelm me as well too. But the voices, not so much. And, I was medicated for a while in therapy, and it didn't really click for me, the experiences that I had in therapy. There were little things that would help me, but ultimately it wasn't jiving with me so much. Like I wasn't really overcoming anything, and I still struggled. It was more so nice to have someone to talk to and feel like I wasn't crazy, but I still struggled every day with panic attacks and overwhelming myself. And there were points that I would lock myself in a basement for a week because I couldn't handle the outside world and all this, like the overwhelming stimulation that it brought. And I had to drop out of college my first year, and I had to stop driving because I would freak out whenever I was behind the wheel. And my mommy had to drive me to work every day. And to cope, I used drugs and alcohol quite a bit, because that at least made my weirdness feel like it was there for a reason. Like, oh, I'm dizzy and seeing things and feeling things because I'm messed up on drugs right now, right? And that was how my life went for quite some time, until I was working in a corporate environment and met a woman who posed this new idea to me that my experiences might be something that's a little more spiritual. And that really resonated for me, that the things that were happening for me might not necessarily be a terrible thing, but just something that I could be experiencing, like energy or spirit. And I took that and I ran with it. And I joined communities of people who had very similar experiences to me, but didn't see them as a problem. They saw these experiences as something that were, I don't even want to necessarily say the word gift, because it's something that we believe that like everybody had the ability to do. But that it was something beyond myself that I was experiencing that I really just ultimately needed to learn how to work with. So building that community and not feeling so alone and actually meeting people who had like experiences was huge for me. But then we also learned coping techniques, because even in the spiritual world, people get overwhelmed by stuff. You know, if you got dead people yapping in your ear all day long, that's not necessarily comfortable. Or if you're feeling energy all day long, that's not necessarily comfortable either. So we learned skills like boundary setting and visualization, and working with our voices, which we would refer to as spirit guides, or spirits. So working with them, communicating to them, don't come near me, or come back later, I'm busy right now, or really fostering a relationship with the experiences that we were having, whether it was the voices or feeling energy or seeing energy or whatever it was. And using that as a way to sort of take control of our personal energy and how we experience it in the world. And that was life-changing. When I learned all of that stuff, I was able to get off of meds, and I wasn't having panic attacks every day. I wasn't falling into this depression. I wasn't using alcohol as a coping skill anymore, but I was with the tools that I gained and working with my community to continue empowering me and empowering myself through that. And it was awesome. And when I was in that and came out of it on the other side, I was like, holy shit, how many people struggle like I did and might be slapped on meds or put into therapy that isn't working for them, and they could literally just maybe learn some of these skills, maybe not necessarily calling spirit or energy or even seeing it from a spiritual perspective, but being able to just use the same skills, use the same techniques to learn how to control of their experience or have some influence over their experience without being so overwhelmed by it. And at the time, I had left my corporate environment once I got my life together, and I started a healing center, and I was working as a psychic medium and doing Reiki, which we were talking about before, and teaching classes and helping people with these experiences that they were being really overwhelmed by. And I was working on getting my license as a therapist as well, because I realized that the people that I really wanted to help, it didn't just stop with people who saw things as a spiritual thing, or saw these experiences as spiritual. But I wanted to infiltrate psychiatry because there were going to be a lot of people there who were going to be the ones that were going to be slapped on meds, and maybe learning techniques that weren't helpful, or maybe told that they had a problem. Because if there was any example of someone who heard voices and it wasn't a fucking problem, ooh, pardon my French, it was me. And so I really wanted to find a way to help people in that way. And along this little journey, one of my friends who's also a psychic medium was participating in a study at Yale on clairaudient mediums, which are people who identify as mediums, but they can hear spirits. And he asked me if I wanted to participate in this study. And I was like, okay. And lo and behold, this Dr. Al Powers was leading this study, and I met Al. And that is where our little adventure began, with starting towards this co-project. I don't know if this is where you want to.
Sure. I'll take that. I'll take that alley-oop. Yeah. So I'm Al. So pause right there. Like think about, where Brittany is and where we actually met, and I can give you my background leading up to that point as well. So I'm Al. So I grew up about 10 miles from here in North Branford, Connecticut. Went to North Branford High School. Go T-Birds. And then came here to Yale for undergraduate, and then in here I studied cognitive science, mostly because I was really interested in just generally how we perceive things, for the most part. I've told Brittany this before. I don't think I've ever told it to this many people before, but when I was a teenager, I had these kinds of really harrowing experiences, which at the time it was harrowing for me because I was not used to it. But there are experiences with hypnagogic hallucinations. So when I was going to sleep, I would experience things in my room, and there were sometimes really bizarre things I couldn't make sense of. Sometimes they were really frightening. Didn't know what was happening at all. Over the course of time, they went away, and so I was able to kind of generally cope with them. But I think that's probably related to the fact that I ended up later on studying perception and trying to understand how we perceive things. I'm sure that's probably very directly related to that. And so when I got to Yale and I decided to be a cognitive science major, I really focused on how do we actually understand what the world is around us, and how do we use our senses to be able to do that? And how does our brain do that in general? How does that happen? And so after I graduated from Yale, I went down to Vanderbilt, which is in Nashville, Connecticut, Nashville, Tennessee. And there I studied neuroscience. So I'm an MD PhD, and my neuroscience work there was mostly taking a look at how the brain puts together information from the different senses, right? And like, how do we know that when someone's speaking and there's no delay like there is right now on Zoom, and you see someone's mouth moving and you hear their voices, their voice kind of coming from that, how do you know that that's actually because of the same external event? Well, the brain actually has to do a bunch of calculations to make that happen. And then there's all sorts of other questions like, well, maybe if the brain doesn't do that very well, how like changeable is that process? Like, can you make that better, not using medications, but using just learning, like mechanisms related to learning? And at this time, I was really interested in, well, the brain, right? And so when you're an MD, or soon to be aspiring MD, you and you think brain, at least at Vanderbilt, in a lot of cases, it was, you know, we think neurology or neurosurgery. And I was actually the student interest group and neurology leader for like 5 years. I'm pretty sure I was going to do neurology. And I found that the questions that they're asking in those departments were just not the ones that really made me interested or excited. They didn't really have all that much to do with someone's experience, but more to do with, well, the brain is an organ like that needs blood, and when it doesn't get blood, bad stuff happens. And I wanted to kind of be a little bit more nuanced about it and try to understand what someone's experience was and how that experience shapes their life. And so I, you know, at that point, I hadn't hit psychiatry. I hadn't even been considering psychiatry at all. And I went to my psychiatry inpatient rotation that was in a psychosis unit at Vanderbilt, and I met one patient. Sometimes it really just takes one patient. It was an 18-year-old young man who you could tell, I mean, even when you talk to him, he was very charming and nice, and enjoyable to talk with. And he, prior to when I'd seen him, was like a star on the soccer team, a ton of friends, doing really well in school. And by the time I'd seen him, he had been isolating in his room for a couple months, didn't want to see anybody. And that was because he had an idea that everybody surrounding him was an imposter, was actually a robot. And I remember his dad getting to that unit and trying to meet with him, and he wouldn't see him. And it was like the most heartbreaking thing I'd seen. It was like a really dramatic medical thing, the most dramatic medical thing I'd seen in medical school. And having just studied how the brain perceives things and how we like develop beliefs about things, it was something that I thought we maybe could make a dent in and maybe try to help with, from the perspective that the brain perceives stuff. That's what it does. And if we are able to understand just how that machinery is just, you know, slightly tweaked, because we all share the same machinery, you know, we might get some insight into how that happens. And so I decided to go into psychiatry. And I came up to Yale, back to Yale, close to my family, which my, you know, very enthusiastic, large Italian family was very excited about. And I came back here to Yale and decided I was going to be studying the symptoms of psychosis. And I decided to work with several people who do work in early psychosis clinically. So Vinod Triari, who's here, and Scott Woods, who we still work with in the Prime Clinic. And then from the research side of things, with Phil Corlett, who has done a lot of stuff on how beliefs are actually formed within a computational framework. And that is where I decided to really study what the field had been calling hallucinations. And most people, when I talk to them, would call voice hearing in particular, because we're talking about auditory verbal hallucinations. And try to understand that from the perspective of how does the brain perceive stuff in general. And I think, you know, before we kind of get to that initial study that we worked together on, and why I decided to recruit Brittany and her friends to it, I want to say that, you know, this you know, webinar was billed as non-pharmaceutical, and that's true. And the fact that, you know, we're not focusing on pharmaceutical stuff. Oftentimes, though, when people think about pharmaceutical stuff, they think of it as, you know, kind of anti-neurobiology. And I would like to make the case that, you know, I study neurobiology, and one of the reasons I study neurobiology is because I think it can be a really normalizing force. Here's what I mean. And the fact that I study how the brain perceives things. And if you study how the brain perceives things and sees everyone's experience as part of, you know, that particular system, then really that kind of automatically kind of normalizes those experiences. If and some people have actually called it a kind of an unothering experience, by kind of putting everything and everybody's experiences on the same framework. And so even though we do study neurobiology, I think this is a way of studying neurobiology that doesn't label and doesn't put someone's experiences, you know, as separate and broken or anything like that. It's really trying to unify human experience and trying to really understand where everybody's coming from. I'll get off my soapbox. So at that point, I decided to study voice hearing experiences, and particularly as separate from what you often will see in the clinic, which is like, well, you know, people who have these experiences after they seek help and would be diagnosed with psychosis if they saw someone in psychiatry and mental health. And the reason why we wanted to get people who had voice hearing experiences outside of those contexts is because we're interested in understanding how well those voice hearing experiences exist. How do they work, right? And particularly, how does the perceptual system function in those particular situations? And so we decided to recruit a bunch of people who had those experiences who never sought help for them. And that was you might hear my son, he's 3. I think he's asking for a peanut butter and jelly sandwich.
I was about to say, I'm hearing voices right now.
So am I. It's my son. Most of the time it is him when I hear him. So we were interested in like how someone actually does come to hear voices within that kind of understanding of perception, and so we recruited people who didn't need help, and Brittany was one of them. We put them through some kind of bunch of not super interesting but very important perceptual tasks, where you're trying to hear something kind of over and over again when it's difficult to hear it, and using as much information as you can to do it. And okay, hi bud. I apologize.
A dad life, you know.
Yeah, dad life. Anyway, so that's and so from there on, so there on we had this particular we had this study going on, and actually I'm going to go ahead and try to see if I can get him to go upstairs, and I'm going to pass it off to Brittany to talk about that study and from there on. Okay, hold on one second.
Oh, that's amazing. So I'll fill in the blanks from what Al was just going to say. So he had us participate in this study, and one thing that he found, that I'm speaking for him right now, but I've heard this story so many times that I could just pretend to be him. One thing that he found very interesting as a psychiatrist is that we were actually able to quote unquote control our experiences, or there was this idea of control that presented itself within the framework of these mediums that he and his colleagues were interviewing. I was just sharing with them the thing that you found so fascinating was that people could foster control.
Yeah, so as a psychiatrist, I had talked to a bunch of people, you know, as you might imagine, during the course of training, and mostly in early psychosis. And I had never met anyone who said, well, you know, I had these experiences, but I have complete control over them. As in, you know, this happened when I was 14 years old, and I developed a ability to not only hear these experiences, but actually, you know, in working with them and negotiating with them, you know, develop some degree to actually make them happen and not happen, which is remarkable. Like, it was something that I had never even heard before. And this is true. I mean, I had experienced a lot of people who were relatively progressive in psychiatry at the time. Yale in general is a very progressive kind of place, including people in the recovery movement. I had, at that point, met the incomparable Claire Bien, who had an amazing story and had, you know, achieved an amazing amount of recovery as well. But you know, even so, this is a situation where I was kind of floored by hearing that particular experience firsthand. And I thought that this is something that yeah, someone must have described or like tried to measure or done something with neurobiologically, and they hadn't. When it comes down to it, there's one item on one clinician rating scale about how much control someone has over their voice hearing experiences. And literally, that's it. It's like in the SIRADs, you ask the clinician, how much does the person in front of you have control over their experiences? And that is kind of backward in my opinion, in the fact that like you're not finding anything out about the person himself or herself or themselves who is experiencing these things and having control or developing control of those experiences, but are asking the clinician, and that was just kind of really out of the it just wasn't where I thought we should be going. And so we decided to kind of get together and create a project in which we really learn from people about their experiences and how they're able to develop control over them, or at least some influence over them, or some degree of agency over those experiences, because that agency, as is illustrated in Brittany's story and in Claire's story and a lot of other people's stories, is really critical in terms of functioning and someone's ability to actually achieve what they need and want to achieve. So that's how we decided to start the co-project together.
Might I interject for a quick moment?
Please do.
We keep talking about control over experiences, and I always think it's important for us to talk a little bit about that. And also the fact that control over one's experiences extends beyond the voice hearing experience.
Absolutely.
But any perceptual experience or even anything in life, right? Like how much control can I exert over how I respond to a situation, which is ultimately what we are getting at when we're looking at control over anything that we're looking at in this this little scope. So with whether it's voices or other perceptual experiences, the question we're really asking is not how do I control, if I'm using voices as the example, the voice itself, because for many of us, we believe that the voice is someone other than ourselves. So how am I supposed to control somebody that's not me, right? And I always joke, like, my mom is super annoying. I can't control my mom,
Not within our control.
But I can control how I respond to my mom. I could yell at her, I could scream at her, I could freak out on her, like, you're so annoying, mom, get out of my face. Or I could work with her and establish a relationship that's going to work for both of us, where we're both going to stay in the same comfort or within the comfort level that we want. So it's more about how do we control ourselves? How do we control how we respond to the situation? And what are the steps we can take after that to, whether that's create boundaries or establish a relationship or work with the experience that we're having rather than against the experience that we're having, which is often what you see. We have this experience that's uncomfortable. Our first response is to like run the other way and like, no, I'm not supposed to be having this experience right now. We want to like dial it back a little, because a lot of the people who we've talked to, including myself, because I talk to myself, what we do is work with the experience. And that's really where we wanted to connect people and get a better understanding of what people in all different communities do. My jam was like the spiritual community and psychic mediums, but there's people from all different communities who have perceptual experiences. And there was similar threads throughout all of the communities in how they, or not similar threads, you know what I'm trying to say, similarities throughout the communities in terms of the skills that they use to establish control. So we really wanted to hear it from them firsthand, what those techniques are, what those tools are, what those belief systems are that help them to establish this sense of control.
Right. So as we kind of, Brittany was one participant in this particular study, right? But after actually talking with her, and like a good year later, she actually asked whether or not she could be a part of the lab, and also, right. So we kind of skipped over that part.
Yeah, my voices brought me to Al.
Yeah, that's right. Well, you can tell that story if you like. I think we have a few minutes before, our 45 minutes is up. Yeah.
Yeah, basically, when you go to get your license to be a therapist, you have to put in clinical hours, and most of the spots that that I found, they weren't really connecting with me much. And I was laying in bed one night, and one of my guides was like, "Contact Dr. Powers," and I'm like, "Who?" Because this was like a year and a half later that I participated in the study. So I
No,
don't
that's
know
okay.
what
That's usually the reaction I get, actually.
Hey, have you talked to Al Who? You
What?
work with him.
Yeah.
Oh, that guy. Yeah, so I was like, there is no way. And they were like, email him. They didn't say it like that, but I was just like, fine. So I just like shot him over an email basically to see if there were any studies going on in anxiety, I think is what I was
We
initially
initially asked about. Yeah, that's right.
and then we met, and then he was like, I have a better idea. Want to help me with this study? And I was just like, obviously. And the rest is sort of history.
Yeah, a couple years later, more than that now, years later since you actually
You
contacted
knew
me.
me when I was a wee one.
Yeah, no, well, and it's been, yeah, and so actually having gotten a chance to talk to Brittany, it was clear that our priorities were exactly in the same place, and this is a really good way to kind of team up and make as much impact as we possibly can. And so that's what we're trying to do with this COPE project. And so the COPE project, when I was gone, did you talk about COPE?
You were on for literally 30 seconds. So I got one sentence out.
You talk really fast. So we decided to get together and try to do exactly that. I think someone actually already asked, have we developed a measure to be able to measure control over voice hearing experiences? And well, yeah, so we have. The key there was to really try to validate and make sure it's measuring exactly what we're hoping it is going to measure, and to really determine what should be on the scale, not based upon what I think of as a psychiatrist, but based upon people's experiences and what they tell us about those experiences. And so we developed a massive scale and tested it out on a bunch of different people who have a bunch of different kinds of experiences. And then we realized that we need to really reach as many people as possible to figure out if this thing is really measuring what we need to measure. And so we came up with this idea of kind of doing what we're doing, what we kind of in microcosm, Brittany and I did already, which is to kind of like form an alliance between, people who have lived experience and particularly experience with recovery, and someone in psychiatry, which would be me, and to try to make that alliance work for us and kind of move things forward. And so we established a group of networks, a kind of a network of networks that we call the Spirit Alliance, whose members kind of run the gamut between people who are interested in the recovery movement, who have lived experience with voice hearing in that way, also people from spiritual organizations, and people from general kind of psychiatry, kind of all getting together to figure out how best we can kind of tackle this problem, and to also tap into the networks of people who are involved, and be able to actually tell us more about what those experiences are like and what it's like to actually develop control over one's experiences. And so we developed this project called the COPE project, the Yale COPE project, which is the Control Over Perceptual Experiences project, as an offshoot or really the first project of the Spirit Alliance. And that was really to get a firsthand report from people who had these experiences, what it's like to develop control. And then ask them a bunch of other stuff. So like, what exactly are your experiences like? And not only use scales and stuff for that, but also get them to tell us in their own words. And then also, because again, I'm a neuroscientist and stuff, trying to understand what people's experiences or what their perception actually kind of looks like. And so I asked them to do a bunch of fun and not so fun games online to be able to inform us, even if they're sitting in their living room in like Iowa, or farthest away we've gotten from COPE so far is like Romania, or
I think it was Romania.
Yeah, there've been a bunch of people in South America as well, so sitting somewhere in the world that is not New Haven, Connecticut, and we could still tell a little bit about how their brain processes sensory information, which can be really important because as you get more and more people and you study exactly how they've mentioned how they're able to develop control over those experiences, we might be able to kind of tap into something about how the brain's able to do that. And if that's the case, we can have a multi-pronged, kind of a bunch of different ways of approaching helping someone develop control, and again, a non-pharmaceutical kind of way.
I think we totally didn't, well, I mean, we kind of talked about what the goal of COPE is, but the goal of COPE is really for us to learn from people with lived experience to do a whole number of things, including establishing treatment in non-pharmaceutical ways to help them develop that control and just to feel well. Yeah. But I feel like there was something else I wanted to add about COPE, and now I can't remember what it was.
I'm sure to come back.
We just showed up, so I think that means.
I think we were just about 5 minutes early with our introduction of ourselves. So that's.
He's on it.
I feel good about that. That's not always the case.
Yeah. So thank you so much, Brittany, and all for that. Always fascinating to hear your stories and kind of learn about what's going on in the academic world and out at Yale, specifically how you're changing the academic world from out in Yale. I know there are a lot of questions from the chat, so let's just dive in maybe to the 15 minutes of questions that I had prepared that I wanted to make sure were covered.
Sure.
And then we'll kind of go through the participant questions. That sounds good. So the first question is kind of for both of you, and it's about stigma and kind of the biases that we have. A lot of people in the lived experience community actually have a lot of bias about academics and providers. You know, as Brittany was saying, she was trying to infiltrate psychiatry. And I think it's very revealing. And Al, I'm sure that, you know, even as you were starting these studies, you must have had some bias against people who hear voices and actually have lived experience. So if you guys can tell us a bit more, both of you can tell us a bit more about your journey, how you grew from each other, like, you know, and kind of got moved past that bias.
Do you want to start or do you want me to start?
Go for it, and then I can kind of maybe halfway respond to you.
Yeah, awesome. I mean, first of all, I think it's important to acknowledge that it is so freaking fair for people, especially in the recovery movement, to have a bias against psychiatrists and mental health. Because there have been a lot of dirty players in psychiatry. You know, it hasn't been rainbows and sunshine the whole time. So I could see that, you know. I've had my fair share of butting heads with a lot of different types of doctors in general, you know, but I feel like that's also being a human. We're going to butt heads with different humans who come from different belief systems and different ways of viewing how to operate in the world. And it's not always going to be something that lines up with our beliefs and our ideals. So I feel like that's something that we're going to face just in being human siblings. But yeah, I feel like it's totally valid. And on the other hand, I also know that there's a ton of people out there who are amazing clinicians and people who really do just want to help. And I'm really thankful to be a part of what feels like a generation of healers who are in it to truly help. I feel like we've become more open in the mental health world to advocacy and recovery movements and peer-led networks more so than we've ever been, which I think is awesome. And I think that that's very important because I do remember being in therapy when I was a teenager and like telling my therapist about anxiety and her like nodding and telling me what to do. And I remember like I was such a douche when I was a teenager. I was just like, you don't know what the hell I'm talking about. You've never been in this situation. And like, I was just like so argumentative because like, how could you possibly understand? So like, I feel like that is something I'm so happy is more commonly seen today. But anyway, as far as my removing my bias, I knew where I was coming from. And I know that I'm not some person that's that freaking unique. You know what I mean? So like there's other people out there who are obviously going to be coming at it from the same place I am. And if I exist, they exist. So that was my way of doing this. But I knew that if I really wanted to make change in mental health, I needed to be on the front lines of mental health and getting to the people who are going to be seen as patients. And I wasn't going to do that in my little cushy private practice where we meditate and do Reiki and stuff. Even though I still love that and still do it, it's something that if I really wanted to make that change, I had to join forces and work together rather than try to do it outside of that. So that's my spiel.
Yeah, from my perspective, I think, Dimitri, your question directed at me was like, how did I overcome my own kind of implicit bias, as a member of the psychiatric community? And I think part of that, it comes with training, really, when it comes down to it. My real, because I mentioned, like, I came to psychiatry pretty late, and, I decided to come to Yale, mostly for the neurobiology more than anything else. And, but Yale is a very, very progressive place. And I think this is true this is true probably across the board in a lot of different places in this country, but Yale is specifically this way. I mean, so Larry Davidson has been here for many years in the department, kind of advocating for a kind of a different view of psychosis in particular, and severe mental illness in general, and has been a really clear voice for the recovery movement as well in general at Yale. The people I trained with in most of my outpatient psychiatric training was in early psychosis, and so there you're working with young people who have their own dreams and aspirations, and it was not a situation where there's a clinician who is 80 years old who says you're never going to be doing all the things you hope to be able to do, which is oftentimes the terrible stories that you hear that people have gone through. And as Brittany mentioned, psychiatry has done a lot of harm for a lot of people over many decades. But I think in some academic medical centers, and particularly at Yale, I think there is a way forward, and there's a generational difference in a lot of ways. All the training I got was very person-centered, was very empathic. And so it wasn't much of a leap, really, to go from, yes, it's important to understand the person's experiences. Yes, it's important to prioritize whatever their priorities actually are as a person, and to help and inform in the best ways you can, the best way you can, and using whatever tools you can to help to inform that. It was a very small step to really go from that to say, I'm taking your experiences very seriously, and I'm here to learn from you about those experiences because I don't have those. And understanding those is the first step to really understanding how best we can move you toward those goals that you define yourself. I think that was not really that much of a leap.
Amazing. Thank you both. That's, I think, a very important part of this conversation. And for me, always one of the most beautiful part of your dynamic is kind of your backgrounds and that story. Next question that I wanted to talk about, having read some of your work, enjoyed it even, I dare say.
All right, we got one.
part of what one of your papers had shown is kind of the initial response from the community of those who hear voices and have visions is like a vital variable in whether they go on to have a positive experience or a negative experience. Kind of the paper I'm thinking about, I'm sure you know exactly which one, also talks about locking into beliefs. And I know a lot of people in the chat have been asking questions for specific strategies. So can you talk a bit more about the implications of that work and some of your later work on the role of community and on the role of belief locking?
Absolutely. I think, yeah, absolutely. So, the work that you're talking about is that schizophrenia bulletin paper from 2017. And it was taking a look at voice hearing experiences in that same group that Brittany was actually part of. I don't know if that's actually legal, but I just said that. But so this group
outed me.
Sorry. But taking a look at those experiences and trying to understand not only what those experiences are and how they're subtly the same or different from people who have sought help for those experiences, but also like what were those initial experiences like, and what were their support groups kind of like, and at the time when they first shared those experiences, what were those experiences like, and what was your support like then? And what we found, as you alluded to, is that people in the psychic medium group, in particular, the non-clinical voice hearing group, were more likely to have a younger age of onset, is what they reported, which is very similar to a bunch of different cohorts across the world. But also, I think we were the first ones to ask, well, what was it like when you shared those experiences with someone you found important? Like, what was it like to tell them that you were hearing something other people weren't hearing? And most people who were in the non-clinical group reported having a neutral or positive experience in reporting that, as opposed to people in the clinical group who mostly got negative or neutral experiences. So there was a big difference there, and it made me think back to the idea that, we talk about kind of strongly held beliefs, and particularly like in the psychiatric community, it's a fixed false belief is a delusion, right? And is what people will define it as, and that kind of ignores to me the idea that, yes, so the idea might be fixed, but there are different kinds of fixed false beliefs. There are a bunch of different kinds and imbalances of those experiences. So I might believe something very, very strongly, but if it's helping me get up and do the things I need to do, that is a very different experience, and will make a much different, very different impact on my life compared to something that is terrifying or causes me to isolate or other things. So those kind of fixed beliefs are a part of, I think, probably the earliest stages of what we as a medical community would call psychosis, and what maybe could be actually intervened upon very early. So it might be that somebody is going to develop very strong beliefs about the world, but you might work with them to kind of foster beliefs that are more functional. It might help them, again, to achieve the things that they want to and need to achieve. So that, I don't know if that necessarily addresses your question.
Yeah. I just want to follow up to kind of, there's something very interesting in that for me. It almost sounds like you're saying, I'm taking a leap here, I admit it almost sounds like you're saying the framework itself doesn't matter, the core nature of the belief doesn't matter, the focus is simply on, are these beliefs helpful or hurtful?
Yeah, I would stand by that, to be honest with you. And actually, that's backed up by data too, not just because that's my gut, right? When it comes down to it, when we take a look at, now a lot of data coming in from around the world, and looking at people who do hear voices, and whether or not they're likely to function very well. Actually, it doesn't have anything at all to do with how frequent the voices happen, or how loud they are, or anything like that. It's really the beliefs about those voices that really matter. And that includes things about, whether the voices themselves are seen as omnipotent. Can they really change things? And are they malevolent? Are they likely to harm you or want to harm you? Those two beliefs in particular seem to really predict how well or poorly you're likely to function. And we've known this now for 5 years or so, 5-10 years, and yet we haven't necessarily taken advantage of that and trying to develop new ways of intervening.
Great. Okay, so I basically just have one more question before we'll dive in to the community's questions. There have been quite a few in the chat, so I want to make sure we get to them.
Sure.
And that is about the current COPE project. I know that also having completed the study myself, it's not the most interesting thing to go through, but it is so for the actual movement and for changing academia and how we think about hearing voices and having visions. So I wanted to kind of get you to talk more about what people can do to sign up, how they can refer people, and also just really talk more about how you're not only what we in the lived experience community talk about as mining people's heads, going in and grabbing the useful data and then throwing them out, but providing additional resources and making sure people get information on what works for them.
Yeah, Britt, you want to handle that one?
Yeah, sure. So the project it's actually very simple if you do want to participate, and I'll just briefly go over what it is that is involved in participating in the study. It's essentially all done from the comfort of your own space, and you just need access to the interwebs and you're on this, so you have access to the interwebs. It's online surveys, and some of the tasks that Al was talking about earlier that just allow us to see how you're perceiving the world, which is super cool. And the surveys are really extensive. So we don't just ask about, you know, tell me when you started hearing voices and what does it sound like? But we ask, as Al says, really fine grain.
I usually make that hand movement, so she's just making fun of me now.
But we ask a lot of details, not just about voices, but about all perceptual experiences, from the onset to the time that it was the strongest, to the time that it was the most controlled, to what your beliefs are about that. We ask about your trauma history. We ask about your personal beliefs on control. We allow you to tell your story in your own words, whether you're typing it, recording it, audio recording it, however you want to do that, because we want to hear about it, not just through that very like dry, sterile, like question, true or false, question A, B, or C, but through your own words, so then we can find commonalities between all of the stories that we're getting to help us to shape better care for people. And as Dimitri said, throughout it, you know, we're talking about different resources for trauma, resources for hearing voices. Al and I are also a resource to talk about. I talk to dozens of people every month who participate in this study, and some of them are really distressed and are looking for help. And I help point them to groups like the HVN in their community and things like that, and finding resources for them. Because, you know, even though this is a study, we still are essentially establishing a community in a way too, of being able to help each other, which is ultimately our goal, right? And yeah, so to participate in that, it's quite simple. You just have to go to our website, which Dimitri, I don't know if that's something you share with everybody, or if
put it out to the chat if you like.
Yeah.
Oh,
And then I'll send it in a follow-up email as well, but if you could just put it in the chat for now.
Yep, I'll do that.
awesome. And you could sign up right through our website. You can send to participate in the study right there on our website. It is a study that is limited to ages 18 to 65 right now. And once you consent, it's basically our system sends you an email, you click on the link, and you really just go through it right then. Yeah, and once a month we offer a webinar. So if you have questions about things, Al and I are also very accessible through email. So if you wanted to chat about anything, you just send us an email.
Yeah, I get emails all the time, and I'm always happy to chat and pop emails. Usually what I'll do is probably copy Brittany on it, and we'll kind of have a conversation about it, or maybe set up a time to talk if we need to. So yeah.
Awesome.
Did I answer all the questions? I wasn't sure.
Knocked that out of the park, Brittany.
Thanks.
Cool. Also, again, you know, as someone with lived experience, I think I'm not alone in kind of thanking you for being human during all this. I know Alfred also put it in the chat, but like, you know, talking like real people to real people, having the additional resources, and not just kind of trying to get more numbers for your study and mine their data, but keeping it human. It means a lot.
No, absolutely. I mean, I think that's why we're doing this in a lot of ways, which is great. But thank you. I appreciate that.
Yeah. And sorry that my human mouth is a potty mouth.
Yeah. My 3-year-old cannot hear Brittany. Don't worry.
I swear like a trucker. My dad hates it.
Okay, so I'm gonna dive in and start going through the questions people were asking throughout. I do think we'll have enough time to go for.
I know it was so hard for me not to pay attention and try to address the questions.
I know. I
they're
keep
going,
like ignoring them.
Yeah, there are a lot of really great questions here. So thanks, guys, for engaging.
So just starting in order, a question from Linda, which is managing meds, and I think just talking about the broader topic. For me, anytime I recommend a psychiatrist, I tell people to kind of look for the word taper in the conversation. But can you tell us a bit more about like coming off meds and your perspective on pharmaceuticals when you're pursuing non-pharmaceutical research?
Do you want to do the
either way,
psychiatrist? Either way,
okay, I'm happy to do it. So, my perspective on medications, so full disclosure, I still prescribe medications, right? I think for me, and maybe I'm, please correct me if I'm wrong, or please disagree with me. That's okay. But when I think about medications, and this is how the clinic that Brittany and I are both a part of, the Yale Prime Clinic, kind of approaches things, and how in general kind of relatively progressive early episode clinics also kind of approach things, is to think about medications as not the end all be all in any way, but really as just like one tool potentially in an armamentarium. And so, for example, if someone comes to me and is not into medications, doesn't want to take medications, that's fine. When it comes down to it, there's really no reason. There's no reason not to. The question would be, what potentially could medications do for someone? And that, I think, is the missing piece here, and why so many people have had so many terrible experiences with medications in the past, because they've gone to someone, said, "Hey, I hear voices," and they say, "Take this medication or you're out." And that is not, that is a terrible thing to do to someone, and is bordering a medical malpractice. But also, it's missing the spirit of the thing, and the spirit of the thing should be, let me talk to this person who's in front of me, who is having difficulty doing something that they need to do in their life, just as I would if I had some difficulty, right? And they're coming to me to ask for help and being able to do the things that they are finding themselves, in a difficult spot, not being able to do. And so, if medications can help that in some ways, so for example, I can give you an example of someone I saw in the first episode of the clinic. This is someone who was a 23-year-old gentleman who came to us, who was having a hard time initially because he, again, was paranoid, thought people were following him, and then over the course of time became increasingly disorganized, unable to kind of do the things he otherwise would do, and that was also kind of mixed up with a bunch of drug use and things like that too. But by the time I saw him, he was not only paranoid, but also he was unable to understand language and unable to produce, language that actually anyone else could really understand. And at that point, I don't know of anything else that could have helped except for starting a medication. And that's not to say that, we started him on like a massive amount of medication and he magically got better or anything like that. We started him on a very small amount of medication, and just to the point where he was able to tell us what was going on. And when he did that, we were able to actually, and utilize all the other resources of the clinic. So a clinic like ours has, individual therapists and family-focused therapy, and career specialists, like vocational specialists and educational specialists, and all sorts of people who are, again, not just like aiming at like, hey, make this person take their medications. They're aiming at like, okay, this person needs to get back to college. So like, how do we make that happen as a team? And the first step might be medications, but the first step might not be. And if they're able to cope with the therapy that they're having and able to achieve the things they need to achieve, then it might be the case that medications don't have a place. And I'm okay with that. I think that's I hope a reasonable approach. Yeah.
No, that was great. That was great. Thanks.
Sure.
Kind of tagging on the logical follow-up question in my mind from the chat, not from me this time. It could be hard for providers who want to advocate for these new approaches or to disclose their own past experience to kind of move against the establishment. Talking a bit in your experience or in your recommendations, how to create change in the less progressive places. And that includes whether, you have specific references that you want to cite or just going off of that broadly. How do you be the change?
How do you be the change? I mean, I think that again starts with, it depends on what the change you're trying to make might be, but learning from the people that are going to be most impacted by that change, I think, is the most important thing, and being open to that and not thinking that you have the answer, because you don't. When it comes down to it, I certainly didn't, and I don't think I still do. But I think my position is to continue to learn from people who have experiences in order to kind of brainstorm and think about ways to make things better. And in terms of like resistance, we really haven't gotten all that much in the way of resistance. Here, again, it's a privileged position because again, it's like not a, it's a place where people have had these conversations and started these conversations probably when it was very difficult to have those conversations, when Larry and others were having those conversations back a couple decades ago. I think starting with a position of humility matters, and trying to learn from each other and not seeing yourself as an expert in everything. I think from my perspective is probably the most important part.
And engage in the research, because the more you engage in the research, the more we can
Sure.
pump out publications.
Well, I mean, that's the thing, is that people will read your work eventually, and you start. Yeah, I guess that's a really good point, Britt, is because knowing medicine from the inside, and you now kind of know medicine from the inside too. People learn about and will trust new information if it comes to them in the form of a publication or some kind of academic medium. And if that's the case, then you're going to want to be able to do that. You want to produce, the kind of evidence that people are going to take seriously. And so, for example, if we had some kind of intervention, whether it be a medication or otherwise, what people are going to want to see is that the thing works. And the way people do that is by doing a randomized control trial of it. And those are expensive, and could take a long time. But if you want to provide evidence that something works, the way to make medicine and psychiatry and whoever else, pay attention to it. That's the way to do it, is to speak their language. Yeah.
Awesome. Okay, so switching gears a bit, and talking more about the skill sets that you've been finding. Like Rhea was asking, how does the skill set of building relationships with your experienced entities dovetail with the insights of internal family systems therapy or Buddhism? And I think personally, I'd like to hear Brittany lead off with this.
Yeah.
What other frameworks she's come across and where she's seeing patterns?
Yeah, that's a great question. You see these techniques through all different belief systems. So it's not like something that's very specific to any one belief system. So whether you have a spiritual framework for it or not, what we're seeing is that people really do find some benefit or peace, not everybody, but many people who we've talked to, through really just taking the time to listen to what the voice might be telling them, and finding a way to meet the needs of that voice, if there is one as well. I've heard that quite a bit, whether that's something coming from a spiritual framework or not. But I see, and Al, you can chime in too, but I feel like we see a lot of similarities between all of these different frameworks, including not just, connecting to the voices, but having that normalization across all of the different communities. And no matter where you're coming from, having other people who think like you, or at the very least have experiences like you, and don't look at you like you're crazy, but like, oh yeah, okay, I have that. It makes you feel like a freaking person, and it makes you feel like a human, and it doesn't make you feel like you have to, that you're separate from anyone else. And I think that that's really one of the most telling things to me in all of the interviews that we've done, is that feeling like you're a person and that you don't have to be looked at as other than, or that there's something wrong with you, has been the most impactful thing, aside from just those really like specific techniques. I feel like overall normalizing things is the first step through all of that.
Right.
Yeah. I'm totally rambling. I don't even know if I answered
That
the
was good.
question. I just like ran with my words and just don't even know what the hell I just said.
Awesome.
Yeah, so I think so. Just real quickly to kind of supplement that, if that's all right. You know, we're about to publish a paper, you know, soon, looking at the way in which people do develop a degree of agency over those experiences, looking at people who have had clinical exposure and people who haven't. And it turns out like the key ingredients, the key steps that people go through are actually very similar. And those key ingredients don't necessarily have to do with like, oh, I think my voices are this particular spirit guide, or you know, someone I knew when I was in middle school or something like that, just to give two examples. That those specific beliefs don't matter. But again, getting back to the question you asked about beliefs earlier, Dimitri, is it's having a belief about whether or not you can gain agency over those experiences, whether or not you are, you know, broken, like a pathologizing versus a non-pathologizing kind of framework for understanding those experiences, acceptance from your social group, and eventually the idea that engagement might matter for these processes. Because I think what ends up happening is that, again, people will, you know, either flee from those experiences or engage with them. And in engagement, I think we see a higher likelihood of actually being able to exert some degree of agency over them.
Great. Okay, thanks. Knocking out kind of 3 questions that I feel are related. Maybe, maybe not. We'll see.
Sure. Yeah.
So the main focus of the co-project, as I understand, is kind of voices and visions. But can you talk a bit more about how that intersects with other unusual experiences, and also what you're seeing in terms of patterns of paranoia and trauma?
Yeah. Just to speak on the perceptual experiences, I feel like it has been, and especially with the spiritual communities, we see often that you're not just isolated. It's not one perceptual experience only. It kind of comes with a slew of other perceptual experiences. One thing that's really stood out to me personally is how many people aren't necessarily affected by the visual or the auditory things, but how those things make them feel, and that discomfort that comes with it, and how there's a lot of tactile things that come with that. And that probably stood out to me most because very similar to my experience, but it is
normalizing for you.
Yeah, totally normalizing for me. But yeah, I noticed that's something that it's coupled a lot, and we're noticing that even just because like we group people through the co-project just to help us understand the different groups, like how many people have both auditory and visual, how many people have just auditory or just visual, and seeing just one is actually kind of hard. Correct me if I'm wrong, Al.
No, totally. That's exactly right. And yeah, I mean, actually, that was something that was again striking for me. Is like I came to this particular community and like wanting to know what their voice hearing experiences are like, right? And oftentimes I'd be told like, I guess it came as a voice, and then they'll like, yeah, it did, that time did come as a voice. And the reason why is that the information content was the thing that seemed to be most important for them. They got a message in some way or knew something, and knowing that was actually important, but not necessarily the modality, the sensory modality came through. And that was actually really interesting to me in terms of thinking about other things. So like I think you also asked about like unusual or very fixed beliefs as well, and what that has to do with it. Again, thinking about beliefs as having a valence in addition to a strength, I think matters a lot. And then also thinking about their ability to kind of, I don't know if you want to call it executive function, but kind of take everything that they have in front of them and manipulate it in a way that actually is functional for them. I think that's an important thing to be able to consider and to meet someone where they are.
Before I kind of reframe the question about the paranoia and trauma, I want to add something here. It's been coming up a lot. There was a study by Tanya Luhrmann from Stanford that valence, or for those who don't know, the quality of voices, whether they're nice or mean, essentially, varies from culture to culture. And all the work you're doing, just based on where we are, is in the Western. It's Western research building upon Western history and traditions. Can you talk a bit more about how, as you've been investigating this, some of the Eastern perspectives on voices, or any cultural perspectives other than the West, on hearing voices, on treatment, on hospitalization, and on the whole situation have played into your lives and your work.
Yeah.
Yeah, so again, this is, it's an international study in some ways, right? But you're right in the fact that just about everybody who participates has to speak English to some degree. We haven't translated into other languages yet. We're interested in doing that. And it's also true that there's massive cultural variation here. And in some societies, particularly like traditional societies in India, for example, and which I think is also another one of Tanya's work, and it's also Larry Davidson's stuff. People with voices generally hear kind of helpful voices, and so the valence of those voices, the content of those voices, it may very well be different. And this actually gets at something that someone in the chat actually I saw earlier, I mentioned as well, which is kind of this relationship with beliefs about the voices, and whether there's correlation or causation with regard to that. And I think, there's actually the beliefs, the expectations someone has can influence not only their voices, but what the voices actually may be saying as well. So for example, we met someone, the very first trip that we ever took together, Brittany and I, was to go to Lilydale, New York, which is the home of America's oldest spiritualist community, and which means that they've been there since the 1800s. And there are some families who of voicers in that particular community whose grandmother was there in the beginning of Lilydale, and then whose mother was there, and then their sisters are all have similar kind of clairaudient experiences. And when we asked them, hey, do you ever have like bad ones? Like, are they ever saying anything bad to you at all? They looked at us like we had 10 heads. Like that is just not something that that was even within their realm of possibility. Their belief was such that if spirit is going to reach out to you, it's going to be good. And so even within subcultures in our own Western culture, I think that might be true. And again, it speaks to the fact that your expectations influence what you're actually perceiving, which, from a neuroscience and kind of like computational perspective, is exactly what we're showing in a kind of a different way.
Awesome. Okay. I know a few people, or quite a lot of people, have been asking about sending people to your study, which is still so important. So I'm going to give the next slot to those questions. First of all, do you accept money from pharmaceuticals for your study? And are there diagnostic exclusions from the COPE project?
Fun fact, Al is funding this entire study by himself.
Well, not by myself.
Well,
through Yale School of Medicine, Yale Department of Psychiatry. So that just tells you kind of generally what kind of Yale is.
But is Al funding it?
Yes, it was my choice to do that. Yeah.
Yes, and the only criteria, there's no diagnostic criteria to participate in the study. There are exclusions if you have any known seizure disorders or neurological disorders like epilepsy, and that's just for your safety because there's flashing lights in one of the games.
Yeah, we just don't want to hurt you.
Yeah.
First thing,
with any diagnosis, we encourage it, actually.
Yeah, absolutely.
So yeah, if somebody said, if you happen to have people who you think are good fits, or you work with inpatient, outpatient, you could tell Al and Brittany are the direct point of contact. So there's no kind of third or fourth person who might be meaner than these two. This is
no, that's us.
And I am mean.
She is. Watch out. I mean, she doesn't look mean here, but she is. Yeah, watch out.
So yes, of course, please do send people, and Al and Brittany always do try to make their conclusions available, whether through publications or
absolutely
emails.
Yep.
I'll make sure that we say that. Okay. Let me see what else was there.
Oh, that's a great. Actually, do you mind if I hit one? That is, do
Yeah, I
providers of
saw
information
that.
get any feedback or information? Not the providers, but the people themselves. And so, one of the things that we wanted to really offer to people, if they do participate, is a distillation of what they're telling us, because we encourage people to share what those experiences are like for them, with the people who are important to them. That might be providers, it might be family members, but we thought we would be able to provide like a little blurb or like a little figure that would be able to, help them explain, hey, in general, this is kind of what my voice hearing experience is like, or this is kind of these are the kinds of things I maybe utilize to help me cope with those. By providing that back to the person, we thought that might be a way of encouraging them or giving them information about what they just told us, and then allow them to communicate that effectively to people who are important to them.
Awesome. Okay. And yeah, okay, so I think we have about 10 minutes left. One of the main questions that still, I'm not sure we fully addressed, was how to break through to somebody who might be in crisis or going through difficulties. Any recommendations you have about how to talk to somebody in distress and get them to kind of accept help from whatever resources are available?
Allie, you
It's a
want to
tough
take
one.
that?
Either way. So it's hard, and I think when it comes down to it, if someone is in crisis, they're in crisis in a lot of ways, partly because they're having a difficult time connecting to people who are able to, able to help or able to get through it enough to help, and that requires establishing trust. And as a provider, it's really difficult to establish trust with someone, especially in certain settings, right? So I see somebody in the emergency department, right? They're locked in a place that they don't feel like they should be. They are maybe not treated very well by some people who are there to supposedly help. It's hard to walk in there and say, "Hi, I'm here to help you," and have them believe you, for completely understandable ways, completely understandable reasons. And so I think taking time, letting someone know that you were there to try to understand and that you have no other agenda, actually probably helps. It depends. Again, if they're really in a crisis, and that means they're probably in an emergency setting. Safety is paramount in the first place. To make sure that someone is safe is the most important part. Is probably why they might be in an emergency setting in the first place. And then an outpatient side of things, so thinking about someone who is, and maybe in the first episode, it might be helpful to think about, talking to them about certainly not medications, not even things that we're going to do in the clinic, but really just try to understand them, is maybe the first thing, because I think even just communicating to someone that that all treatment or all interactions with providers in your clinic or wherever you're kind of offering that help, are guided by what they need, is an important thing to communicate. And it may be that that person is not able to hear that or not able to necessarily understand that. And in those situations, again, in the past, I've found some medications at a very low dose could be helpful, but that might not always be the case. And there are many others, I imagine, particularly, I think, in people with lived experience in the recovery movement, in the Hearing Voices Network in particular, who might be able to answer that question better than I can. So there are many people who have found themselves in crisis and can tell you exactly what they would have liked to have heard or been able to have received effectively at that time. And I would, again, in the spirit of not being an expert in that, in everything, I would defer to them.
Awesome. Okay, so I think we have time for one more question before we kind of do a wrap up, and a quick thank you to the speakers. That question is, you said one of the key focuses has been, but all these questions are mostly coming from the chat, so I'm not just, yeah. One of the key focuses is on the voices being benevolent rather than malicious. Can you give some specific examples of how to create that change and any other coping mechanisms that your work has already shown? Just kind of get into the specifics.
Yeah, sure. I think, Britt, you might, we actually just, we've been working actually a little bit with Tanya Lerman about some of these questions as well. And I had a little conversation with Britt earlier about like trying to understand the kind of training that someone might go through within a spiritual context and trying to like essentially offer protection to oneself. And I think those practices might actually be of particular help here in thinking about kind of differentiating, distinguishing between good and bad voices and trying to influence that.
Yeah. I mean, and I always come from the perspective that like, if I'm looking at my voices as a human, whether it's coming from me or coming from someone else, when we're angry, there's obviously something there that's missing. There's a need there that needs to be addressed, at least from my perspective. And I feel like being able to, I talked about a need earlier, if we can connect to that voice and connect to what that need is, sometimes we can almost transmute or transform that voice from something that is angry to, at the very least, something that's indifferent. And that's something I heard from quite a few participants as well, that they might have this angry voice, whether it's childlike or like an angry man or whatever. And they, rather than fighting against them and be like, shut up, or trying to muffle them and shut them out, which is something that probably would anger anyone more. You know, you're crying out for help for something, or you're pissed about something. Think about a little kid, right? Like if a little kid comes storming in here and they're pissed about something, am I going to be like, get the hell out of here, throw it out the window? No. I'm going to ask the kid, what's going on? Like, why are you so mad? Well, Al said he'd
for the record, I just did. No, just kidding. No, but you're right. I mean, so actually, in that way, actually, the hearing voices movements approaches in a lot of ways are really helpful, right? So thinking about voices not as kind of these things that are in your way or harmful or irritating or anything, but maybe potentially as part of oneself or part of one's past, and treating them as you would want to treat them as if they were actually part of yourself, might be a very kind of good way to start. And so there are a lot of books to read on that too.
Yeah. And some people just come, so Al was mentioning that we were talking about little techniques that people might use from the psychic medium community or spiritual communities. A lot of people utilize protection. So, you know, protecting themselves from these energies that might feel negative, and that can be helpful for people too, without actually engaging with the voices. Or using the good voices that they have, if they have a mix of good and bad, to help facilitate or help in that protection. So, I mean, there's not like a one technique fits all. It really is an individual experience, and it depends on what each individual person is going through and what their different voices are and the dynamics there, and how to work with the person in front of you and within their framework to help.
Absolutely.
Awesome. So I want to take the time to thank you both again for being speakers. As you can see from the comments, if you've been reading them, a lot of people are very grateful, very informative and kind of uplifting to hear you both talk. So thank you for joining us. We got about 150 attendees.
Yeah, that's really excellent. And thank you all for having us. This is really a wonderful experience, and we'd like to reach out as much as we possibly can. Also, I know there are a bunch of questions and stuff in there that we just haven't had a chance to really get to, and just limited time. I can go ahead and put my email in there, and
I'll put mine too.
Yeah, and that way, like, if you guys have questions that haven't been answered that you'd like to kind of just have a discussion about, please do. Just reach out. We're not gonna bite, promise.
Great. If anybody wants to rewatch it, that's one of the questions. It is being recorded, and we'll send that out as well. Thank you, everyone, not only to the speakers, but everyone who joined.
Thank you.
And for donating to ISPS-US. Very important work connecting the lived experience community with academics and providers and families. So yeah, appreciate it. And Al, Brittany, thank you for the work, and I'm sure we'll be in touch.
Thanks, Dimitri. Thanks
for having us.
Appreciate it.
Thanks, everyone.